Briefly, I am Scott Sunseth. I am the director of the International Health Cohorts Consortium of the IHCC. And it gives me a great privilege to introduce to you our next plenary speaker. We heard from Patrick this morning when he gave his welcome address, but let me reintroduce him to you. Professor Patrick Tan is the Executive Director of Precision Health Research, or PRECISE, and as Executive Director of PRECISE, Professor Tan oversees the implementation of Phase 2 of Singapore's precision medicine strategy, which aims to transform healthcare in Singapore and improve patient outcomes through new insights into the Asian genome and data-driven healthcare solutions. Professor Tan is also the Senior Vice Dean of Research at the Duke National University of Singapore Medical School and Chief Scientific Officer at the Genome Institute of Singapore, the Agency for Science, Technology and Research, or ASTAR. Finally, he was also one of the lead principal investigators for Phase 1 of the National Precision Medicine Program here in Singapore, and we are privileged to have him share his invaluable perspectives on that with his talk. Professor Tan.
Okay, thanks very much, everybody, for being here, and we hope that you are enjoying the session. Thanks to Scott and IHCC for putting this together. What I'd like to do in the next 25 minutes or so is to take you on the journey for Singapore's National Precision Medicine Program, and to set a context of how we view this, about this concept of value. How do we provide value to the country through a program like the NPM program in three areas: in the area of research, improvements in healthcare, as well as what we refer to as economic value capture. So I hope that you find these topics of interest. So I'm going to start off with something that most of us in Singapore know about, but most of people outside Singapore may not know about, and that's a program called Healthier SG. What Healthier SG is, and by the Ministry of Health, is nothing less than a mega transformation of the way that Singapore delivers healthcare, which traditionally has been in the tertiary centers, treating patients with disease. But what Healthier SG is to transform that focus of healthcare to promoting health and disease prevention. Healthier SG was started about late last year, and we just finished, just a few weeks ago, 1 million sign-ups to the Healthier SG program. At the heart of Healthier SG is really a localization of each Singaporean towards a general practitioner that they can see and consult with over the course of their lifetime in a way to provide advice on screening, exercise, disease prevention, and health-promoting behaviors. So this is moving health from treating disease towards improving and maintaining health. So this is great, right? And as round of this, hopefully, a lot of people will stop smoking, exercise more, eat less, which is hard to do in Singapore. And here comes an interesting potential tension, because obviously everybody should do these things. So what is the role and the value of precision in this focus on public and population health? And this is actually a tension, because many of these population health efforts are really focused upon very large types of interventions. Everybody should do this, everybody should do that. And so that articles like this, like highlighted in Nature, have asked this question: is there a tension between what we're doing in this room on precision and how does it intersect and ultimately contribute towards the health of a population? But I think that if you do a bit deeper on this and move beyond the ability that says everybody should do these general light touch interventions, you begin to think about what precision gives to you, which is really the question of what is the value of the utilization of data about populations and patients in the pursuit of public population health. If you have enough data, you'll be able to predict which segments of the population are at increased disease risk. If you have enough data, you'll be able to accurately diagnose a disease when it happens. And if you have enough data, you'll be able to ascribe which is the right drug for the right patient in that population that ultimately develops a disease condition. So I think what the value of data, and precision medicine is really a data play, is about, is that it provides governments and policymakers ways of assigning resources towards some pretty important questions. And these questions are, well, when we say population health, which population are we talking about? A general population, a pediatric population, an ICU population? Which technology should you use? And some of these technologies are very expensive. Genome sequencing is still a cost, but we're talking about plasma proteomics, imaging studies, wearables. What technology is best used, should best be used? Which intervention in the disease, is it a drug? Is it a behavioral nudge? Is it something as simple as I should tell my first-degree relative that they should go for screening, cascade screening? What intervention is actually most impactful for the population? And finally, when should you do the intervention? You need to do it before the disease has progressed on to its too late. So you need to detect those early warning signals. And ultimately, I think for all of us in this room, if we want to keep our paychecks coming, we need to understand the big killer question, which is ultimately, are these things deployable at scale, and are they financially sustainable? So the concept I want to drive to here is precision value, which means that to different stakeholders in the government, people see value in different ways, and I'm going to try to pick up these strands on how a program, a national program, can deliver value to different segments of different government policy holders. So let me introduce PRECISE, which is focused on the genome, and we are not dismissing other technologies, but we are focused on the genome. And we are here to be able to understand the Asian genome because of our makeup. It also happens that this is underrepresented, but it's not just the genome. It's about also collecting and harnessing information related to healthcare outcomes, lifestyle, environmental, linkage to clinical data, but to do three things that you see on your right-hand side that are actually very simple in statement, but hard to do in terms of actual execution. The first one is that what are the best technologies and populations that we can use to identify people at risk of genetic disease? Monogenic first, but ultimately going to polygenic. Once we know that what those individuals are and who they are, what are the best cost-effective strategies that we can use to intervene? So which intervention do you use to be able to enhance their health, but yet to do so in a way that doesn't blow up the healthcare budget? So this is where the health economics comes in. And finally, as a national program, we talked a lot about concerns about discrimination, about non-appropriate use of genetic information. As a national program, how do we work with government stakeholders to put in the right policies and the regulations such that if you are born with bad genetics, you still have an equal shot at life compared to everybody else? Because nobody told you to decide who your parents are. And I think that's the role of these three things are, and what you can deliver when you're part of a national program. So this is the remit of PRECISE, and my team and I are working at this vision. In order to do this, the program in Singapore is a 3-phase program, about 10 to 15 years. And what we've tried to do is to break it up into bite-sized chunks that we can stop after every phase to show people that there is some value in what we do. Phase 1, very simple, by today's standards, 10,000 genomes, reference genome of Asian normality, just show that we can do that in Singapore, a small country. In phase 2, I'll talk about, and phase 3, and a sneak peek at what we're thinking for the third phase of the program. So the first question is, do we even need to do this at all in Singapore? What value is that in sequencing the Singapore population for insights, but also maybe for healthcare? And here, what I've shown here is on your left-hand side is kind of it's a crude heat map, so take it with a grain of salt, but the different world populations as defined by the 1,000 Genomes Project, so this is a publicly available disease databases. And what you can see in Singapore, we have Chinese, Indians, and Malays are the East Asians in 1,000 genomes mapped against Singapore Chinese, the South Asians in 1,000 genomes mapped against the Indians, and there's nice overlap. Obviously, if I pivot this map a bit, you will see subpopulations. So I want to say this is a first-degree approximation, but it does give you a sense of the diversity of Singapore. And at the bottom here are the Singapore Malay population, which actually has very little representation in 1,000 genomes. And I think one of the things that I know we have representatives from Malaysia here and Indonesia here. We do want to see how we can work together to really tackle this underrepresented population. The information that we have for the first 10,000 is actually publicly available. There is a variant browser that we put in place. It's currently being accessed by users from over 60 different countries. Because there are Asians, not just in Singapore, there are Asians all over the world. And this is something that we do want to work with to share the data that we have with the rest of the global precision medicine community. But I think on the right-hand side, it tells you something that is important for healthcare and screening approaches, is that even if you look at credentialed, highly penetrant disease-causing genes, the rate at which we see pathogenic mutations in the different ethnic groups is different. There are different founder mutations. And so I think that this informs the rate of frequency, and these policies then are informed by your prevalence rates in order for us to design tailored public policy statements. So I think those aspects represent why it's important for every country to understand their own demographic and their own patient population. Now, that was for phase 1. And now I'm going to focus upon maybe our thought process for phase 2. And we had a number of different design principles that we could consider. Do we sequence disease cases? The way that Genomics England, the 100,000 Genomes Project, what do we do? We kind of knew that Healthier SG was going to come online. And so we decided to suggest that we need to set up a population biobank that mimics the general population in Singapore to the best of our extent, that allows us to profile the healthy population and to monitor them as they go from no disease to early disease, because that's the way that you can identify these early warning signals and their mechanisms and the pathways that you can use to try to intervene. And this is a slide that I'm sure many of you have seen before about the value that a longitudinal population biobank gives to you. We also knew that it was always going to be small. It was never going to meet the size of some of the big biobanks in other countries, but it had to be comprehensive and it had to be interoperable with these other efforts. And I think efforts like IHCC and GA4GH play a huge role in this particular process. So we designed, along with Professor John Chambers, who is our CSO, but also the PI, of the SG100 case study. So this is a snapshot of the SG100 case. SMS today was a bit optimistic in his speech today. He said 90,000. We're actually at 87,000, but close enough. But we should be finished with full recruitment of 100,000 by early next year. And for genomes, we've just crossed the 75,000 mark. On the nice cartoon here are the different research phenotypes, the baseline research phenotypes that we collect, all of which are designed to be interoperable with all of us, as well as UK Biobank. And so I think that we were able to cross-operate some of these instruments in order to understand and validate different types of pathways. The other thing that I'll show slide is the ability to link that data from these healthy people with electronic health records so that we can monitor their longitudinal progression whenever they encounter the healthcare system. So this is ongoing. And I think one thing that I wanted to highlight is that are we seeing anything interesting that might motivate a lot of expenditure into this program? And this is just one study that I think was actually presented in a short talk earlier today, where by integrating the genotypic data with the phenotypic data, and carotid intermal thickness, the thickness of the carotid artery, we've been able to find new genes associated with this process, which is a risk factor for cardiovascular disease. But importantly, if you see in the right-hand side, and this is an important point, is that if you look at these and look at the risk even in Caucasian populations, there is a risk there. So what we're seeing here is that we are beginning to explore spaces of the genome that we can understand in Asia simply because those variants are there at higher prevalence. We can see the associations. But ultimately, what we are revealing is not just research phenotypes for Asians, but also that would inform human biology in general. So this is currently on Med Archives. The linkage to the electronic health records data is something that does capitalize upon the fact that Singapore has a national identifier. And this is something that we find is very, very useful because when we link up to the electronic health information, what we get for each individual is a complete record of their electronic health records from birth. So we are able then to monitor their trajectory all the way from the moment they encountered the Singapore healthcare system. And I think this is going to result in a lot of new approaches on how you understand and mine longitudinal outcome data. And we've currently released the first 50,000 fully linked genotypes to research phenotypes, to clinical phenotypes, to the community. Now, that's the research part, and we hope that through this, with new insights, giving it to the research community, we can now provide value for research, which is of great interest to the Ministry of Education and the universities, because they want to publish papers, get grants, be able to galvanize new findings. It's not necessarily the case that the Ministry of Health, I don't know if our colleagues here are that interested in that. What they want to know is how can we take these findings after they're validated, bring them back into the Singapore healthcare system to actually improve outcomes for patients. And so, in addition to the precise SG100 case study, we actually commissioned 5 different clinical implementation pilots that ask the question, if we take conditions of known validated biology, how can we devise clinical pathways in the Singapore healthcare system, couple them with robust health economic analysis to be able to provide use cases that then we can show to the ministry that this improves outcomes and this is cost-effective at the very least. And so there are 5 of these over here. I'm not going to go through all of them, but these are pathfinder use cases for as we get more validated biology through SG100K, through other cohort studies, we can plow them through this same pipeline. I would just like to talk about 2 of these clinical implementation pilots, just to set the stage that it's also a process of implementation science, which is something that I think for us we do need to encourage and to grow beyond the research discovery-based science. The first one is familial hypercholesterolemia. Now, most of you probably know about this condition. It's a prevalent condition, one in our population, maybe 100 to 140 or 50. Untreated, we will probably at high risk for an often lethal heart attack by age 40, which is at a productive time of life, but you can intercept that with a statin or another drug. And the question now is how we can take this, define the clinical pathway, build it up, not just in a specialty lipid clinic in a National Heart Center, but actually in the general community. And we're trying to work throughout those particular processes. Now, cost effectiveness is a very important area that drives a lot of the thought process in the clinical implementation pilots. And this type of format may not be as familiar to most of you here unless you're a health economist. It's called a tornado plot, where if you see anything to the right of the dotted line, that means that that intervention or that interception is cost effective. So by many different metrics, screening for familial hypercholesterolemia is cost effective. But what you can see at the different rows here are the different drivers of that cost effectiveness, meaning that if we can continue to push those and optimize those, we can increase the value of that particular care delivery model. And I want to zoom in on the things at the top, where it turns out that if you have a better way of ascertaining who is likely to have FH before you send them for sequencing, you can actually increase the cost effectiveness of study. So, and this is actually something that, we would like to think that we can sequence everybody, the entire population, but maybe at the start we should be focusing upon those populations most likely to have FH to raise the positive value, raise the cost effectiveness. And so this is where the art of clinical intuition comes into place. If you see at the top, if we just screen and sequence the general population, we get about a pickup rate of about 0.7 to 1%. If you do a lipid cutoff, high lipid value at about 4.9, we increase the pickup rate. But if you see at the bottom, if you send that patient to a lipid clinic by a clinician that knows how to diagnose FH, even at the same biochemical values, and they refer that patient for testing, that pickup rate goes up tenfold. So there's something going on in the brain of the doctor that looks at the patient and says, maybe combining with other biochemical variables, that this patient should be sent for screening. And right now we have a use case where we're working with A*STAR to apply artificial intelligence onto clinical records to be able to see, can we use that to enrich the population that can be sent for sequencing and increase the cost-effectiveness of FH screening. The other one that I would like to highlight as a difference from a monogenic condition like FH is a polygenic condition. In this case, I want to use the example of breast cancer because in this example, despite what you think about Singapore, we have problems. And here I want to highlight this. This is a problem, right? Just look at the box in red at the bottom. In many Western countries, and I've used the US as an example, the acceptance and the take-up rate of breast cancer screening is high, about 70 to 80%. In Singapore and in several Asian countries, our breast cancer screening rate for mammography is actually much lower. And this is just the first time they go. If you look at the time they come back for a second mammography, that's actually number falls down. So the question then arises, can we use genetics to be able to motivate and nudge women to be able to go for more breast cancer screening? And so the intervention here is not a drug like a statin. The intervention here is a behavioral nudge. And so as part of this, the program called BRIEF came out, where we are asking the question, can we recruit individuals, and what is the role of a PRS score in motivating people to go for screening purposes? And so the structure of BRIEF is actually as follows. Women are enrolled in the program, and we document what is their perceived risk of breast cancer through some questionnaire. And then we actually do a PRS score combined with other models, the Gale model, and give them back a report that combines PRS genetic information along with Gale and gives them back their computed risk and asks the question, does this change the way that they perceive their risk? Because we know that the perception of risk is a strong motivator in women, men also, to be able to go for screening. These are some of the results. I don't have time to go through all of the points, but I want to highlight that, in particular, I want to highlight the segment that's 40 to 49 years old, because this is the population where, at the present moment, there is no clear clinical guideline for them to go for their standard mammographies. And over here, when we follow up, in the outer circle, the yellow ribbons are the individuals that eventually develop breast cancer or diagnose, and all of them follow into the high-risk group. So we know that the biology works. We know that these Gale models with genetics can identify the high-risk population. The question is that if you transmit information, will they be more motivated to go for screening? The answer is that we still don't know. If you look at the bottom over here, the women that received the high-risk report did agree that they would embrace that and actually go for screening. We will be monitoring over the course of the next 1.5 years to see if they actually do that. And if we do, we think this will be evidence of how a PRS score can be used to uplift at least our rate of breast cancer screening, which ultimately we think will be beneficial in terms of detecting more cases with interventional breast cancer, those early warning signals. In the last 7 minutes, I would like to highlight, so that's of great interest to the Ministry of Health. That's not of particular interest to the Ministry of Trade and Industry. And so the trade and industry question is that how then can we use this to grow, engage companies in Singapore? Singapore has always tried, the survival of Singapore is required being open and being economically open to have many different countries that are coming in. And we have different engagement patterns with different data companies offering platforms like sequencing, with people doing drug discovery and with people doing new products and services. I'll just highlight some points before I close off my talk today. So one of the key partners, and I do want to acknowledge them, is Illumina. We were able to leverage off the experience they had in doing the 100,000 Genomes project to bring that technology into Singapore and to set it up. But they didn't do it as Illumina. They did it by contracting a local company, hiring more Singaporeans to be able to take on that knowledge and to run the project, and in doing so empowers that company to be able to go and expand its services elsewhere in the region. And that's this company, Novogene AIT. So I think this is one opportunity for a small country to be able to work with these platform companies and retain that expertise in Singapore. Catalyzed by this positive experience, we have now launched, just a few weeks ago, a long-read sequencing initiative combining the capabilities of both ONT and PacBio. Because in Singapore, we want everybody to be friendly with one another. Because there's a lot to do, right? And to do different, it's a complicated slide, but I want to make 2 points. I think firstly, it's very exciting because we're using this for unresolved genetic disease, and we're actually seeing the first solves come out using this technology that has eclipsed and eluded short-read sequencing. But also through this, we've been able to bring these new habits to Singapore so that other users in the universities and the institutes can now use long-read sequencing because now it is offered in Singapore at scale. And on the right-hand side, at the bottom left, are the 4 new people that are now partaking as part of the whole precision medicine ecosystem in Singapore. We are still in our nascent stage of learning how to use this data to find drugs. And obviously the pros at that are the multinational pharmaceutical companies. And so we've been able to think about how we can collaborate with the pharmaceuticals to be able to have public-private partnerships to co-develop and co-invest in how we can mine this information for new drug targets. This is the first of our pharma partners, and we hope to sign on more in the months to come. So this would be the second area. The third area is then how can we use this information to power the local economy? Because, like it or not, Singapore itself still does not have its own pharma company. I wish that we could go and buy one, but. So what we've done here is actually to work with components of the Singapore research ecosystem. It's an effort called DXT Hub, which is funded by the government to translate upstream diagnostic discoveries into a productization platform where they can develop diagnostics that are deployable at scale. And in this case, from the SG10K work in phase 1, we developed an Asian carrier screening platform for carrier diseases that includes things that you know about, SMA and so on, but other conditions like citrate deficiency that are less prevalent in the West. And this is now being rolled out. I think that, you'll hear about next month, so I can say it now. This work, after the product is done, will be supported by Temasek Foundation, which is one of our big foundations, to roll out over 30,000 families in Singapore. So that will give us the scale that we need to be able to see the impact of carrier screening in the country. So last 2 slides, that's phase 2, phase 1 and phase 2. So what about phase 3? And this is just a sneak peek. It's still in the planning phase. But if you think about the role of the phase 2 is about the general population. We think there will be value in phase 3 to think about how we can bring these technologies into the population of Singapore that's actively using healthcare services. And at the bottom is just a chart of how Singapore healthcare is divided into 3 clusters, and each cluster has its own suite of hospitals and specialty centers. And why do we want to do this? We think there's an opportunity here to do 2 things. Firstly, to use this to transform the way healthcare delivery is done, where the genome is part of your clinical record. And also, in a busy slide again, we think that by looking at disease cases, we'll now also be able to look at things that we can't really look at in a population cohort. Disease progression, for instance. treatments with drug therapies and what are their conditions and what are their pharmacogenomic markers. You can't do that if it's a healthy population. So I think that those are the things that we are very excited about. We're still working through that. We need to engage our clinical partners, but we think this is an area that we do feel is perhaps worth going to. So I want to end up this part, and just as my own belief system, we ask the question, what population should you first target for precision medicine? What technology should you use? What intervention and when? And we have many different technologies at play, but I would argue to you that the genome is the one technology that doesn't change, that everybody, regardless of what population you start off with, will use at some point in their life. And so I think that it's a good place to use the genome as an enabling platform to be able to ask what population, what tech, and what intervention with the new RNA therapeutics coming in. So with this, I'd like to say we're still a journey, but thank you very much for your time, and thanks. Enjoy the rest of the conference. Thank you.